So let me now just jump to treatment issues. And so there's some interesting ways to bring this all together. And this is a nice study from Ajay Wasan, who's at Brigham and Women's and used to be at Hopkins. And what he did was he took patients with chronic low back pain and brought them into the clinical research unit and infused them with morphine. And what he found was that the group that had high scores on negative affect, the components that I've been talking about in terms of catastrophizing and anxiety and depression, showed much less of an opioid response, kind of a reduction in their pain to this opioid infusion than the group that had low negative affect. Okay, so this brings it now to what's happening in the pain clinic and the treatments that are being tested. I don't know if Raj is going to talk about this earlier, but Rob Edwards did this interesting study in the context of a clinical trial that Raj did. We were interested in, was there anything about pain sensitivity at baseline that could help us understand who were the opioid responders during this, in this trial. And what you see is that the group that had the best opioid response, so they had at least 30% reduction in their pain when they were given an oral opioid, they were less pain sensitive. So this means less pain sensitive than the group that were not very opioid responsive. So again, and we think that there are many things that contribute to pain sensitivity, but some of these cognitive and affective processes are some of the candidates. So then let me talk to you a little bit about psychological treatment of chronic pain. And there's a large literature on this. There are the usual debates that there are in any literature. But some of the psychological treatments are focused on pain, but they're also very much focused on the dimensions that I just talked about, with the exception of sleep often. And so the focus in a psychological treatment is on pain catastrophizing, it's on negative emotions, it's on other coping strategies, it's on disability and function, and it is, by the way, focused on pain. But the emphasis is less on pain than it is on these other components. But what happens pretty consistently in the literature is that these kinds of interventions reduce pain, they reduce pain-related disability and pain behaviors. They increase patients' perceptions of control and sense of self-efficacy and their ability to manage their pain, reduce helplessness. They improve a patient's emotional state, so reduce some of these negative emotions I've been talking about. And they change the coping profile so that people are using less pain catastrophizing and more active coping strategies. And then some of the interesting studies in rheumatoid arthritis where you actually have a biological marker of disease activity, there's some studies that demonstrate that these treatments actually change some of the biological markers. And just to kind of raise some of the issues that I think are important in the field, these interventions are done really late stage in chronic pain. And this is a nice study where people with rheumatoid arthritis were treated very early in the trajectory of their disease. And what you see here is that CBT, or cognitive behavioral treatment, was able to reduce depression scores, basically, compared to usual care over an 18-month period. And so some of the future directions that we're talking about in my group and kind of nationally with people who are interested in these kinds of factors in pain is that we've got to start to understand kind of the combined and separate effects of these components. There is a correlation between anxiety, depression, and catastrophizing. We've kind of pulled that out. We know that there's a unique kind of factor of catastrophizing, especially in the laboratory. We don't often see changes in mood when we poke and prod people, but we see changes in catastrophizing. We're very interested in, we've got a study now that NIDCR has funded where we're looking at catastrophizing and sleep disturbance, because there is some overlap and there's some separation, so we're trying to understand that better. As I mentioned, that there are some biological, there are a number of biological underpinnings of these factors, and we're starting to study kind of the pathophysiology of both anxiety, depression, catastrophizing, and sleep. And we're particularly interested in how these influence central pain processing, and we've got some studies on that I decided not to include today. And then the other issue about treatment, particularly in the studies of the psychological treatments, is we know that there's a chunk of people, like in any pain treatment, that don't get better. And so we're talking a lot in our community about improving our treatments, enhancing them by developing them further, but also trying to understand the subgroup effect that we see in lots of different chronic pain treatments.